So I want to recognize everyone who got here in time and want to officially welcome you and everyone else listening in this session. Welcome to EATG's Scope Community Meeting. You can read our title here. All what we are going to do for the next 90 minutes is we're going to learn and discuss about the developments in the HIV and STI biomedical prevention pipeline. And even reading this shows how complex and interesting this update for community educators and advocates is. Some of you might have wondered about the title Scope, and the 5 letters that we see here are one of the famous acronyms EATG is famous for, because it says it's an abbreviation of the Strategic Community HIV Prevention Empowerment. So you see the 2 most important words here. It's about community and empowerment. My name is Harriet Langanke, or when it gets to official international context, it's Harriet Langanke, and I'm always happy to read my name in Cyrillic letters, as you can see here. And reading Cyrillic letters reminds me to remind you about our session being translated by where's Olga and where is our Vladimir, right? Those 2 people, they are helping us to translate from English into Russian. So in adding to our housekeeping rules, I want to remind myself and all of us to speak as slowly and clearly as possible, because this will help our Russian-speaking audience to better understand what we are talking about. As I said, my name is Harriet Langanke, and I'm EATG's chair for the Combination Prevention Program. And I'm personally very much interested in about learning what is the SCOPE project, how is the SCOPE project that we are going to share today, how it is contributing to, and I think we have a slide showing that, how to strengthen the community engagement to reduce any gaps in access and use of HIV combination prevention interventions. I'm also happy to discuss and learn about what platforms we can provide for learning and mutual support. This is one platform that we are sharing today for representatives from especially community-based organizations. The SCOPE program also wants to equip the communities with a scientific and technical knowledge, which is why we will listen to 2 fantastic speakers. I'm very happy to have them here today, Jade Ghosn and Cindra Feuer. And of course, we all want to transform those things that hinder the way to sustained investment in reducing HIV infections. So this was my introduction, and I'm quite well in time, I think. And our group has grown to 37 people, which makes me very happy. And I'm also happy that we will have a wonderful moderator, Richard Stranz, who is going to deal with all your questions, who is trying to help us to find answers to all our questions. And before I hand over to Richard, I think I have the great honor and pleasure to introduce our first speaker, who is based in the Bichat University. Oh, I should work on my French, really. L'Université Bichat, is that some sort of right? At least it's French, and we are going to hear Jade Ghosn. He is professor at the Department of Infectious Diseases at this university. I hope I pronounced somehow correctly Bichat. Jade, please correct me if I was wrong, and if there is nothing else hindering us in starting with the program, I'm very happy to hand over to you, your slides, and just to answer the most important question coming with sessions like these. Yes, we can share the slides afterwards. You will find them, and you don't have to take your cell phone and secretly try to have pictures of it. It's all going to be shared. Hoping for my EATG colleagues in the staff in the office. What did I forget before I can hand over to Jade Ghosn? Is there anything? I don't think so. Jade, then
Thank you, Harriet. Thank you all. Good
very
morning.
welcome, and the floor is yours.
Thank you. I'm very happy to be with you today. And Harriet, your French pronunciation was just great. Bichat is Bichat, and it's really, that's the way to pronounce it. I just wanted to start with my disclosures before starting with the topic I was asked to talk to you about, which is updates in PrEP and biomedical prevention of STI. So first, you all know this slide showing that PrEP with TDF-FTC achieve great levels of protection against HIV infection in clinical trials. One of the issues with oral PrEP with TDF-FTC, it's adherence to the daily regimen. And we now have accumulating data of the fact that effectiveness improves with adherence to PrEP. One of the ways to improve adherence was to try and have oral PrEP on demand rather than having it on a daily basis. And this was demonstrated by the Hypergate trial, which was conducted in France and in Canada, showing that on-demand PrEP with TDF-FTC was as effective as oral daily PrEP with TDF-FTC. And WHO has now endorsed the recommendation of PrEP 2+1+1 on an on-demand basis since 2019. I'm sorry, I have an issue with my computer. We have set up a cohort in Paris and the suburban area, which is called the Prevenir cohort, to have data on PrEP in a real life setting rather than in clinical trials. So we have enrolled 30,000 participants in this cohort since May 2017. And participants who agreed to be enrolled in this cohort can choose to take PrEP on a daily basis or on demand, and they can switch from one regimen to another all across the study period. They are followed up according to French recommendation every 3 months, with a fourth ELISA HIV test performed every 3 months, renal function test, and STI screening. We now have the results of this cohort after a 2-year follow-up. These are baseline characteristics, and you see that participants, half of the participants, 1,500, chose to take PrEP on a daily basis, and the other half chose to take PrEP on demand. And these are their characteristics, and you can see that the only characteristics that differ between the on-demand and the daily group are the number of sexual partners in the last 3 months, which is higher in the daily group than in the on-demand group. And once again, this is not a randomization. Participants choose themselves to take PrEP the way they like to take it, on a daily basis or on demand, and they can also switch from one regimen to another according to their sexual activity during the study period. So we had 6 cases of HIV seroconversion during this 2-year follow-up with 3,000 participants. And you can see that this yields a very low HIV incidence rate, 0.11 for 100 participants year, which is really, really low. And we have a low rate of study discontinuation. And we had 3 seroconversion in people taking PrEP on a daily basis and 3 seroconversion in people taking PrEP on demand. And you can see here that giving PrEP to 3,000 participants for 2 years allowed us to avert 361 HIV infections based on the incidence we had in the placebo group of the HyperGay study that was performed in France. I will not go through this slide in details. I just wanted to show you that all 6 cases who seroconverted had all stopped PrEP weeks before seroconversion. We had no seroconversion in participants taking PrEP at the time of seroconversion. All of them did stop PrEP weeks before seroconversion and after, but they continued to have highly at-risk sexual behavior while having discontinued PrEP several weeks before. So we really have challenge with TDF-FTC on an oral PrEP. Yes, it yields 100% protection in high-risk MSM when you take it on a regular basis and when you adhere fully to the PrEP regimen, but there are barriers such as forgetfulness, competing priorities, safety concerns, stigma, partners' negative feelings toward PrEP, and suboptimal uptake and coverage. So one of the ways to deal with these gaps or these barriers to oral PrEP is to address this issue with long-acting intramuscular PrEP. And we now have very robust data with cabotegravir, which is an integrase inhibitor that is given intramuscular every 2 months. And this was the HPTN 083 study that was performed in MSM, showing that CAB was superior to oral TDF-FTC on a daily basis with a reduction in HIV incidence above 70% with the cabotegravir. And this was again superior to TDF-FTC on a daily basis. We also have the same results in the 084 study, which was restricted to women. Also in the 084 study, a significant reduction in HIV incidence in cabotegravir arm that was superior to the TDF-FTC oral arm on a daily basis. One issue with this cabotegravir intramuscular injection is that, yes, we have very low rate of failure, 18 seroconversion in the study HPTN 083 out of more than 2,000 participants, which is very low. But we had 6 out of the 18 who did comply to injection schedule. So in these 6 failure, we do not have an explanation on why did they seroconvert while they were complying to the injection schedule every 2 months. For the others, we know that there were some delays in the injection schedule, and this might explain the fact that they did seroconvert. But for these 6, these are really challenging, and we do not fully understand why they did acquire HIV while they did comply to injection schedule. Another drawback of this cabotegravir long-acting intramuscular injection is the delay in identifying HIV seroconversion while on cabotegravir long-acting PrEP. You can see here in this trial participant, the first HIV test that was detected on site was after 40 weeks since enrollment. But when you retrospectively tested all the samples before, you can see that there was a 3 months delay before for the identification of the seroconversion on site. And when performing more sensitive assays, they were able to identify the seroconversion on samples drawn 3 months before. So there's a 3 months delay for the detection of HIV infection, which yields to the selection of resistance in this individual to all the integrase inhibitor class. And you can see here that the virus had acquired two major resistance mutation in the integrase gene that yield high-level resistance to all the integrase class, which is really a problem for future therapeutic options for this individual. So yes, very high rates of protection, very low rates of seroconversion, but two issues. One, with seroconversion happening in individuals fully complying to injection schedules, and the other issue is the delay in the detection of HIV infection because of this long-acting antiretroviral exposure. We now have also preliminary data on another long-acting agent, lenacapavir, which is a capsid inhibitor who is given subcutaneously every 6 months. So you can self-administer the drug subcutaneously. This is not the same way with cabotegravir, which is intramuscular, and you need a healthcare worker to provide the injection. So these are results on macaque studies after rectal challenge with SHIV, and you can see that the highest dose of lenacapavir here, given subcutaneously, yields high rates of protection after intrarectal challenges. We also have very strong results in a macaque model also after vaginal challenge with 100% protection of female macaque after vaginal challenges with the highest dose of lenacapavir given subcutaneously. And trials in humans are actually being conducted. We did also hear at CROI about a rectal insert of TAF plus elvitegravir, which is also an integrase inhibitor. This might be interesting because some people might be reluctant to pill taken every day or injections, and they might maybe prefer a local device for PrEP, such as this rectal insert. And to date, pharmacokinetic data shows that you need to have 2 rectal inserts inserted at the same time, 2 inserts, and these 2 inserts might yield protection for 72 hours. So this might be interesting. You have a 3-day protection after inserting 2 rectal inserts in the rectum, and the tolerance data seems good till now. And I think that this rectal insert might also go into development in further clinical trials. So let us move now to STI. You know that STI is a growing issue in the MSM population globally, and especially in the MSM population in PrEP users. So these are the doxy PEP results. This is a trial conducted in the US that was conducted in people living with HIV and in MSM or trans men to female on PrEP, with doxycycline given as a post-exposure prophylaxis, which is 2 pills up to 72 hours after a condomless sexual intercourse. And there was a doxy PEP arm and a no PEP arm, and participants were screened every 3 months for STI. And you can see here the results with a 65% reduction in STI incidence in the doxy PEP arm in comparison to the no PEP arm. And this was true in the PrEP cohort and in people living with HIV. So we had the same results in people living with HIV and in PrEP users with a 65% reduction in STI globally. And this was true for chlamydia, for syphilis, and also for gonococcal infections, which was unexpected because of a high level of resistance of gonococ to doxycycline. But yet, we still had a significant reduction in gonococcal infection in the doxy PEP arm in comparison to the no PEP arm.
Jade, just a little timekeeping. We've got about 3 or 4 minutes left.
Yeah, I think I have 2 or 3 slides left, so I should stick to the time, no problem. These are the results of the French trial, the DoxyVac trial that were presented at CROI, showing also, you see that an 80% reduction in STI for chlamydia and syphilis with the Doxy PEP, and samely, very significant reduction in chlamydia alone, syphilis alone, but also in gonococcal infection with a 50% reduction in the incidence of gonococcal infection with the Doxy PEP post-exposure prophylaxis, which was really also not expected because of the expected level of resistance of gonococcal infection to doxycycline. In contrast, we also had results of doxycycline as a post-exposure prophylaxis in women in Kenya, and you can see that there was no efficacy of the Doxy PEP to prevent chlamydia infection, which is in great contrast of what we have seen in male individuals. And I will be happy to discuss this issue in the Q&A section right after the talk. So finally, we now have a high efficacious level of protection with antiretroviral. We have TASP for people living with HIV. We have PrEP for HIV negative individuals who are at risk of acquiring HIV. And whatever, I like to quote Sharon Walensky's sentence to conclude my talk: whatever the next hottest scientifically proven HIV treatment or prevention strategies are, PrEP or TASP, they will share a common denominator for implementation, the HIV test. So we all need to learn our HIV status before we can begin. And thank you for your attention. I'm happy to answer your questions.
Thank you, Jade. Wonderful information that you've shared with us there. There is a question that's been asked in the question and answer box. I'm going to ask Jan to ask the question, just to help with a little bit of interactivity. Jan, the floor is yours.
Yes, can you hear me?
Yes, we can hear you. Yes,
wonderful. Well, I just wanted to know if the patients who got the CAP PrEP, cabotegravir PrEP IM, who failed, these were 6 persons. If you looked for the subtype of them, so maybe it was subtype HIV subtype A1 or A6. Did you look for that?
Yeah, this was looked for, and there was no specific subtypes in this 6 failure of cabotegravir PrEP. It was not subtypes A1 or A6.
All right, thank you.
And thank you, Jan. Magda, would you like to ask your question here?
Yes, if I may. I'm wondering, we were talking about Polish expert about it. Is there any difference between using PrEP in hetero and MSM population? So between men, of course, it's different sexual contact, but still, do you recommend only regular PrEP for heterosexual men, or it's also the short one?
There's no short or regular. There's on demand or on daily basis.
That's what I'm thinking, sorry.
Every day or on demand. I think that we have a lot of data that allow us to be sure that PrEP will be as effective in heterosexual men if it's given on demand also.
Thank you, it's very important.
Thank you. Yeah, Jade, you start. Amanita?
Yes, this is actually kind of a follow-up question, maybe just to clarify something that is not very clear to me. As properly mentioned before, the WHO recommends, that PrEP on demand should not be used by cisgender women. But I wonder if this is if it's specifically for cisgender women, or it's because of like basically depending on the type of penetrative sex. So if the receiver, like, is this specifically for cisgender women, or can this apply for any other type of receivers? I'm talking about, for example, between homosexual men, the receiver would be in the same position as a cisgender woman, or like how would be the situation here?
No, the fact that on-demand PrEP with TDF FTC cannot be recommended for cisgender women is mainly driven by the vaginal exposure. It's only the vaginal exposure that prevent the use of TDF FTC on an on-demand basis in cisgender women, because you need a longer time to have protective concentration in the vagina than in the rectum. So even with the double dose that you take, the 2+1+1, the double dose that you take at least 2 hours before does not allow for concentrations to be protective in the vagina, but it allows for protection to be protective in the rectum. So it's really the vaginal exposure that is preventing the use of TDF FTC on an on-demand basis.
Right. Thank you, Amanita. Thank you, Richard. Pietro? And you have a comment.
As a consultant for WHO, I would like just to clarify what is the recommendation. Regarding event-driven PrEP or on-demand, basically the eligibility criteria is to be a person assigned male at birth and not taking exogenous estradiol-based hormone therapy. So basically, and having sexual exposure. But as Jade just noticed, of course, these depend for women, for cisgender women, of course, the discriminatory is if they have vaginal sex or not. So if a cisgender woman has just anal sex, then of course she can use event-driven PrEP. Maybe we need to say this a little bit better in our recommendations. And yeah, and just to point out that the newest recommendations also recommend daily PrEP for people that might be exposed to HIV due to injective practices. And over.
Thank you, Pietro, for that clarification, or at least further information of where WHO is on its recommendations. I had another. Jade, you said that you had you were willing to talk about in more detail about one of your slides. What exactly did you want, or were you prepared to go further into detail on that particular slide?
So yeah, this was really surprising because we had zero effect of doxycycline PEP for women, while we have an 80% reduction in STI incidence in men, people living with HIV, or men on PrEP. And this was really striking. And so there was a lot of hypotheses that were raised to try and explain this failure of doxy PEP in women. One of them was the penetration of doxycycline in the vaginal tissues. And this was addressed, and we now have data suggesting that there are very good concentration of doxycycline in the vagina, as you can see here. It's even higher than what we see in the rectum in blue. The vagina is in blue, the rectum is in orange. So the penetration of doxycycline in the vagina cannot explain this failure of doxy PEP in women. Another explanation was maybe adherence issue in the context of women in Kenya. So this is something that has to be more thoroughly addressed. But yeah, these were the two hypotheses, and I think we really need to know if doxycycline PEP works or not in women to prevent bacterial STI.
Thank you. I also had one last question before we head over to the next. Sorry, my computer screen has just gone black on me. My question was, Jade, what can you talk to us? You mentioned several injectables. What about implants and their the possibility of having an implant instead of an injectable. What have your patients mentioned about that, or what research can you talk to us about at that level?
So there was an implant program that was undergoing with islatravir, but as I think the next speaker will also address this issue, islatravir was put on hold for PrEP studies because of potential toxicity on CD4 and lymphocytes. So as of now, there is no development of islatravir on PrEP. So this implant islatravir is no longer being studied, but there are others options with implants that might come into clinical trials. And I think, yeah, implants that would be biodegradable or that could be refilled or changed once in a year might be also a very good option.
Thank you for that. Right, well, I suggest I can hand the floor back to Harriet to introduce our next speaker. And then we've got about another 10 minutes, I think, of presentation with the next speaker. And then we have a longer period of question and answers after that. I know, Jade, you have to leave us earlier than the end of our session. So perhaps if there are, in that second period of time, there are any other further questions for Jade, please put them in the question and answer box at the bottom. I've also seen that we've had a lot of interaction going on in the chat, which I am watching to see if there are any questions, but please feel free to interact and ask your questions. Harriet?
Yeah, thank you very much, Richard, and first of all, or above all, Jade, for the presentation. I am completely confident that each and everyone who is interested in HIV prevention, especially in biomedical prevention, knows AVAC, AVAC. And this is exactly the organization Cindra Feuer is working for. So Cindra, you are bringing with you a presentation on what we call food for thought for the community. And I'm very happy for those who are not that familiar with AVAC. I will put it in the chat so everyone can look it up, avac.org, because I'm sure you'll refer to many of the resources you're providing there. And if not, prove me different. The floor is yours. Thanks, Cindra.
Thanks so much, Harriet. Hi, everyone. Nice to be here. I'm going to share my screen. And before I move on, just a clarification. Richard, you had said I'm presenting for 10 minutes, but I thought I'm presenting for 20 minutes. So maybe I'll do 15. Yes, no? Okay. So, oops.
Sorry, my mistake, Cindra.
Okay, okay, good. Thank you for that clarification. So, hi, everyone. I'm phoning in from New York. Sorry if I speak fast. If I do, please flag me and I'll try to go more slowly. And I'm trying to advance my slide. Hold on. Hold on. Oh, here we go. Well, okay. So I'm going to pick up where Jade sort of paved the way. And but first I'm gonna back up and give a nice overview of the prevention pipeline, what's in the R&D, sort of a broad picture of that. And then I'm going to go specifically into PrEP, STI PEP, and vaccines. Oh, I don't know if you can see this. It's a very busy slide, but I think it's important to look at the whole field and where these new interventions fit in. So just really briefly, we have what we have already for use for HIV prevention. Everyone knows we've had condoms for decades. We have VMMC, which is voluntary medical male circumcision, and that's actually been it's been recommended for use in heterosexual men only, and mostly in the African context where that's where heterosexual men are most at risk. And as we all know, we have daily oral Truvada or TDF-FTC PrEP. We have event-driven PrEP, and also under review or in trial still is TAF, which is another form of oral PrEP that I'll get into. And there's the dapivirine ring, which is another important new intervention that has been WHO recommended and EMA approved for Africa, not for Europe. And then I want to draw your attention down here. So the green means these are the things that are still in efficacy studies. So they've made it to large scale studies. So as Jade talked about, the lenacapavir, which would be two, well, I'll go into the details later of lenacapavir. And then we also have a dual prevention pill, which I'll talk about, which combines PrEP with contraception. And that's looking very promising to come to market soon. And then AD26 vaccine, this box is red because unfortunately this was the last large-scale vaccine trial that was ongoing, but it has recently, and I believe January, was proven to be ineffective. So we have no HIV vaccines, large-scale, like late stage phases in the pipeline. So it's a little bit of a desert these days. But then if you look here, we've got this box. So there's this BNAB, which stands for broadly neutralizing antibody infusions. And I'll go into these a little bit more. These are showing, we just recently, a couple of years ago, saw a proof of concept, and we're moving ahead with studying BNABs. And then, as Jade also mentioned, this last one is the, they were looking at islatravir. Someone asked about islatravir implants. They were looking at a monthly pill instead of a daily pill. And then unfortunately it had to be discontinued, the study, because it showed that it depleted T cells, not a good thing. So that's a broad overview of the field. But even broader, I want to show you this very busy slide. And here the first column is preclinical. So we've got all of these things in preclinical, and then a few more in, well, a few in phase 1, not many in phase 2, and even less in phase 3, because it's natural that as you move through the pipeline, we pick off the things that are not effective. But really what's important is this column. This column is the active drug that that researchers are studying, and it's filled with different antiretrovirals. So they're taking, I mean, it's mostly antiretrovirals, not all of it. We've got grifocin and things like this, which is derived from seaweed. So they're taking all of these drugs, these experimental, some are experimental, some are already in use for treatment. And then they're taking this column, this is the delivery systems, and they're combining, they're packing these delivery systems, and they're packing all these different drugs into these different ways of delivering these drugs. So we've got diaphragms, enemas, injections, implants, patches, mucosal inserts, oral pills, injections, vaginal film, vaginal gels, and a vaginal ring. And so they're mixing and matching. And then if you look down here, they're also researching multi-prevention technologies where they want in one mechanism, in one delivery system, they want to be able to prevent STIs, HIV, and pregnancy. So all of these are in different stages of experiment, different stages of study. But these, and most of them, not all of them make it to phase 3. And we're focusing mostly, I'm going to focus mostly on phase 3 today, because those are the ones as community we need to really keep our eyes on, because those are the ones that will be, results will come out soonest or soon. And if they do, we need to be able to prepare our communities about how to respond to the results, whether that means to go forward with implementation or how to communicate ones that haven't worked. So I'm going to get very focused on PrEP research right now. So again, I'm focusing just on the efficacy trials, which are the late stage trials, not upstream, not the early ones. So FTAF, which is just another version of what we already have as the standard of oral PrEP, which is TDF-FTC, also known as Truvada. It has been proven to work in cisgender men, and it's only really beneficial for those who have issues with bone density and kidneys. However, it also shows that there's an increase, a pretty significant increase in blood fat levels and weight gain. It has not been studied. Well, it's ongoing. There's a study ongoing now in cisgender women. It wasn't originally studied in cisgender women, so it's only now been proven and recommended for assigned male at birth people. We'll have, and actually this FTF is being studied in cisgender women along with in the actual injectable lenacapavir study, because they're both made by Gilead. And these results are expected in 2024. Importantly for Europe, FTAF is not available in generic form, and it won't be probably for 20 years. Therefore, and in men, it has not been proven to be superior to what we already have as the standard. So is there even a reason to care about this FTAF drug? Maybe there might be in people who have kidney issues or bone issues, but it's something that is a question for the community. And again, the monthly oral efficacy trial of islatravir was discontinued because it had bad side effects. And I talked a little bit about the dual prevention pill, which combines TDF-FTC oral PrEP with contraception. And we're looking at studies for whether this works. Will be out pretty soon, and it could go to market pretty early. And it would be quite revolutionary to have a multi-prevention technology that prevents pregnancy and HIV. Lenacapavir, I think Jade spoke about this. I'm not going to go into too much detail, except for that it's very exciting to know that there is a study, an efficacy study. So it could be, if it's proven to work, it could be at market, within the next couple of years. And this is a 6-monthly injectable. And that means that you would only have to get a shot twice a year to prevent HIV. And it's being studied in South Africa, Uganda, Brazil, Peru, and US. Again, Jade went into the details of the cabotegravir study design and the results. But as community, we need to know and follow some of the outstanding questions that we still have. As Jade mentioned, there were breakthrough infections. I think he said that there were 6 seroconversions that in people who actually complied with their regimens. Moving forward, how best to get people to adhere to 6 clinic visits a year. We don't really know in the real world if that's going to hold up. And he spoke about the potential for resistance with cabotegravir, and the need for testing. I'll go a little bit more into that. That the standard testing was not able to pick up the seroconversions on cabotegravir. There's still questions about safety in pregnancy and breastfeeding. We don't know the best service delivery models. We don't know how it's going to be resourced, especially that's a big question for the community in Europe. And, again, in different geographies and populations that weren't studied in the actual clinical trials, we still need to understand the best way to roll that out. And technically right now, those 2 big studies, they're still ongoing. They're in open label extension trials right now. And as we speak, there are implementation projects rolling out throughout mostly Africa, US, Australia. So the testing, just really quickly, there are concerns about resistant virus because the testing is not, like I said, the standard tests don't pick up if someone is HIV positive and they're on cabotegravir. It takes a while for them to pick it up. Initially, they thought that, so the tail phase is when you go off of cabotegravir, the drug can stay in your body for up to a year. In women, it's longer than a year. And as that drug dissipates, is there vulnerability to more resistant infection? And what the studies showed was no, the actual resistance happened when people were on the drug, were taking the drug actively. Let's see. So as far as testing goes, the ideal test, the strongest test would be viral load testing compared to what's usually a standard of care test. However, this could be really costly. There's a logistic burden, and it's not realistic to be rolling out viral load testing for all HIV prevention for every test. So as advocates, we're recommending that ViiV, the manufacturer of cabotegravir, must engage with the community, especially around fair pricing and equitable access. So far in Europe, it's really unclear if Europe's even going to be able to get a fair price that's actually realistic to roll out when compared to oral PrEP. And we're really trying to put pressure on ViiV. ViiV has a very, and I can talk about this later if there's interest, ViiV has a stock problem right now. They can't manufacture as much as there's a demand for it. So WHO, UNAIDS, and national health ministries and AIDS programs need to have clear plans and milestones and funding and move forward. We need to make sure that we as community are part of that planning and monitor that planning. And we need to make sure that there's implementation science to answer all these outstanding questions, but not sequentially. We don't want to do, we want the science to be done at the same time there's rollout. We know this drug works. How best to get it to the people should be, those questions should be answered as we roll it out. Not like the impact trial in London with oral PrEP, which they said, we're not going to roll it out until we see how best to do it. And it delayed its implementation by several years. So I'm moving on to vaccines. Like I said, there are no large-scale efficacy trials. In the since 2020, 3 trials have failed. And some would say that finding an HIV vaccine has been the biggest scientific challenge, even more difficult than putting humans on the moon. So why do we spend billions of dollars on the, or hundreds of millions each year on the quest for an HIV vaccine? And the answer is, once we do get a vaccine, it would be inexpensive, and it would be, ideally it would be 1 dose, maybe a booster dose every, but ideally one dose. So that would be very inexpensive. And so therefore it would be more equitable if you could get this inexpensive vaccine to everyone. It would be more acceptable if you get 1 dose for your whole life with fewest side effects, and it would be durable. It would last forever. So it's really the most efficient way to prevent HIV. Most of the research is what we're called upstream. So it's in early phases now. So there's a lot being looked at, but it's really in preclinical and phase 1 studies right now. So it's going to be many years before we're even looking at a potential vaccine to take to market. So again, they're in the lab, animal studies, phase 0, phase 1. Lots of different concepts are being looked at. We don't really even know whether an effective vaccine will ever really be achieved, but we have to keep pushing the funding and the interest in going, because again, this could be one of the best ways of preventing and eventually controlling the epidemics. And so just really quickly, these are some of the major strategies that are being looked at as far as vaccines. The first one is the mRNA vaccine. That might sound familiar because that's what the COVID vaccine is based on. And it was also, well, let me back up. This is where you get a vaccine that delivers a genetic material that instructs your body to create a protein fragment of HIV, and then your body sees that protein and responds by creating its own antibody. And there's 3 ongoing trials right now, but again, they're only phase 1 trials. And then there's another promising strategy. It's based on a CMV vector. This is like a herpes virus. And so they're using this vector. It's entering phase 1. And what's really exciting is that this will, they've seen that in monkeys. It actually controlled any monkeys who got infected. It controlled the virus and then it cleared it in all the monkeys. And this would work to elicit T cells, not antibodies. And then I had mentioned earlier, there's these broadly neutralizing antibodies. It's not really a vaccine. It's an infusion of broadly neutralizing antibodies. These are the things that vaccines prompt your body to make in your body. So your body naturally sees a foreign invader like the virus, and it will make broadly neutralizing antibodies. This in people who have been living with HIV for years, they make these broadly neutralizing antibodies. So they've cloned these broadly neutralizing antibodies, and they're infusing them into HIV negative people. And it's actually shown in the AMP study, it was shown to work when you have a strain that responds to that specific antibody. So it was proof of concept, it could work. There's several ongoing phases now, but they're just like antiretrovirals, just like everything, they're combining it. They think that it doesn't need just one. For full prevention, you're going to need a combination of broadly neutralizing antibodies that work against different strains. But they're unsure exactly which antibodies to test. And we're in the beginning of this journey. So the advocacy that we as community need to be doing is the funding of vaccine research. It's gone down globally. It's gone down by 5.5%. However, in the European funding, it's decreased by 31% in just 1 year. So this is something that Europeans need to be really, as an advocates, if you want vaccine and potential eradication of HIV, we need to invest more. As it stands in Europe, we are spending anywhere from 6.3 thousand euros to 15,000 euros a year on people living with HIV.
Just to remind you, Cindra, you've got about two to 3 minutes
Okay,
left.
great. We need to strengthen healthcare systems to ensure that when there is a vaccine, that there's effective and equal distribution. As we learned from COVID, there isn't. Well, we knew before COVID, but it's very clear we need to be working on these systems. And really quickly, I'm just going to go through this new place of research, sexually transmitted infection, PEP. So what is so there's this new thing called doxy-PEP. What is it? So doxycycline is it's a tetracycline. It's an antibiotic that's used to treat bacterial infections, including chlamydia and syphilis. So we're calling it doxy-PEP. You take 200 milligrams within 24 hours of condomless sex, no later than 72 hours. And it's been proven to reduce chlamydia, gonorrhea, and syphilis in gay men. However, studies reducing gonorrhea have been mixed. So it doesn't work as well in gonorrhea because of gonorrhea resistance, especially in Europe. But because there's been 3 large-scale studies that show that it actually works, when I say off-label, people, especially gay men, are taking it now. It hasn't been recommended or approved. There's no guidance or normative guidance by national regulatory saying this is how to use it. So people are using it without real professional guidance. And that actually is concerning because there might be concerns of resistance. Busy slide. Jade went into this a little bit. It just shows the effectiveness of the different doxy studies. I want to draw your attention, importantly, to doxy-VAC, different from doxy PEP. DoxyVac is a vaccine that was studied recently alongside doxy PEP. So DoxyVac, this is a vaccine. It's a meningococcal vaccine that they had observed. This vaccine from meningitis, they had observed that because it's similar, meningitis is similar to gonorrhea, they had observed that it actually reduced the rate of gonorrhea. So they tested it, and sure enough, it did reduce the rates of gonorrhea in a vaccine. And that's good because gonorrhea doesn't work as well. It doesn't respond as well to doxycycline PEP. So they want to combine doxy PEP with the vaccine, which is called 4C-Men-B, so that you would be reducing chlamydia, syphilis, and gonorrhea. However, the study, the ANRS, the French study that showed that the vaccine worked, there's been some, it's undergoing an independent audit now because there's been some data confusion. So we're waiting for that. And as Jade said, it didn't work in women in Kenya. So going forward, there's still a lot of outstanding questions. This is a new area of study, but it's very promising. However, there's a huge potential negative impact on the microbiome. If you're taking doxycycline regularly, it can maybe really reduce the good bacteria in your gut. And of course, there's international concern about antimicrobial drug resistance. So we need more studies to determine how much, if and how much doxy PEP drives antibiotic resistance. We need it in clinical trials, and we need it on a population-based level, this research. We want to understand, why didn't it work in women? Was it their anatomy? Was it adherence? Was it resistance? And we need guidance. We need WHO to come up with guidance. We need national programs to come up with guidance, because people are already using it, and we want to know how best to use it. And then there's the DoxyVac. So we need to know, we want to wait for the results of the independent audit for the one vaccine trial that showed it worked. We want to confirm that we have to confirm that the vaccine worked in other studies. We need confirmation. And how long does the vaccine work for? Does it need a booster? And can a more specific gonorrhea vaccine be developed? And is it cost effective? And I'm going to stop there. This is, if I know that was a lot of information at a short time. So there's all these resources. They're linked here and here. And if you're interested, please find me. Thanks so much for listening.
Thank you, Cindra. Very, very complete and detailed slides at some point, but also well presented, so that we get a very good overview of everything. So questions and answers period is again open. It wasn't ever closed, really. So if you have any questions for Cindra, you can ask them here in the question and answer box, or in the chat, or just raise your hand to ask them. Cindra, I have one for you. We had a quick chat beforehand, and basically the question is sort of like, well, as we have oral PrEP, and there seems to be these questions with injectables, and further down the line, perhaps with implants and stuff like this, why would we need to bother, really, as community and as advocates, in looking for other possible forms of oral PrEP, or of PrEP, when oral PrEP works so well?
It's a really good question. Yeah, oral PrEP works really well in the clinic. I mean, in the clinical trials. And I'll speak in the next webinar. We're going to talk about implementation instead of in the research pipeline. And if you look at the rates of scale up of oral PrEP, they've been slow. It's accelerating. But if we didn't reach there was a goal of by 2020 we were supposed to reach 3 million people on oral PrEP. And we just reached, now in 2023, we just reached 3.9 million, and it's accelerating. But there's a real, so that's, I guess, creating that infrastructure is taking a while, but also there's a real problem with retention on oral PrEP. Like a lot of people, 3.9 million people on the globe have started, but I'll show drop-off rates in our next webinar. They drop off within 3 months. And a lot of it is just people can't or won't or don't want to take an a daily oral pill like every day. And then, you know, we have no idea what it's going to be like to implement an injectable. I mean, everyone's really excited that cabotegravir injectables are going to get it around the whole daily adherence thing. Like you don't have to take a pill every day. You just go to the clinic 6 times a year. But will people go to the clinic? We don't know. We hope there'll be quicker, more accelerated uptake with that. But ultimately, as I said in my thing, a vaccine, you get one shot, you know, one shot in a lifetime, maybe 2 shots in a lifetime. It's inexpensive. It's really the great the equitable eradicator. Sorry if you can't translate that.
I like that one. We'll have to make a song about the great equitable eradicator. I have a memory of a song that used to be called The Great Oral Disseminator. So I'm thinking that could be great. The great.
Who sings that?
It was a guy called Faithless. It was called God. So Great Oral Disseminator. But
right. Oh wait, I want to hear that.
Yeah. Thank you, Cindra, for that overview. Of course, there's another question that links into that, which is follow-up to the community, what we do in France, which is to have these 3 monthly checkups with also on STIs and these other recommendations that would then also need to fit in with the coming in six times a year for an injection or regularly for updating the implants. Yeah, you want to react to that?
Yeah, I want to say something about the 2 times. So I should have put it in the slides, but they're also going to be looking at, they're not doing it yet. They're going to be looking at, okay, so in the cabotegravir trials, they saw that women who didn't take it every 2 months, who missed their every 2 months, they saw that cabotegravir was forgiving and that it actually worked, and it could work a shot every 3 months. So they want to study that because the importance is that women go to the clinic every 3 months to get their contraception shot. And so if they could align that with the schedule of cabotegravir, it might be a lot easier, a lot more accessible.
Okay. Thank you. Right. Okay. Then I have another question, which is also for you and for Jade. And you mentioned at several points what we as community could be looking at or what advocates should be asking for. But is there any particular thing that you would that you identify as being complicated for the community to advocate for, or where they need to get more information from, or shall we say the advocates need to get more information from the community about what the community wants, as opposed to what the community should be doing? My question is perhaps not very clear.
No, I think I understand. What does the community want, right? Well, let me back up a little and talk about choice. As we've seen in the pregnancy prevention field, the more methods you introduce, the more acts of protection, there's more protection globally. So each new intervention introduces more protection. And that's because people might not like what's there and they like the new one. Same with HIV prevention. And I just said that there's reasons why people can't take oral PrEP. Maybe they'll want to take an injection 6 times a year. Maybe they'll want to take it 2 times a year. Maybe want an implant or an insert, which Jade was showing, the insert, which is not systemic. So it's just topical. So you don't always have a drug inside you. And these are choices. Maybe someone wants to use a condom, old school. So whenever we say, what does the community want? I'm not in a position to speak for every individual person, But if we give as many choices as possible, they can choose for themselves. And so let me just talk about cabotegravir. I know that in the beginning, and even now, it is the beginning, there was even from the community and from the activists, there was a little bit of a pushback in Europe, like, this is too expensive. Our clinics are already overburdened. This will never fly. And I said, it's easy for us as activists to be the gatekeepers and say no, but we don't know the individuals. They might prefer that. And let's give people a choice, and then they can make their own choices about whether they take up cabotegravir or not. We don't know what people will want, but it seems pretty acceptable in the study so far. Yeah.
Okay. Yes, I mean, obviously the question of choice is the more choice we have, the more choice we have to make the choice, or the right, or shall we say, a convenient choice in terms of the prevention might be more adapted to us. Jade, I see you've come back. Was that to make a comment?
Yeah, so I totally agree. And I think that another thing that advocacy could do is also make pressure on manufacturers for the pricing of new devices or new drugs used in PrEP, because if they fix a really expensive price, health authorities will never reimburse it, because they will say you have TDF FTC generic oral PrEP. It works very well, and they will never be okay to reimburse a very expensive drug, except for niche populations such as people with kidney, with renal function issues, or bone density issues, or adherence issues, or psychiatric issues. And I think that pricing should be something that is discussed really early in the development, because if a drug shows efficacy in PrEP and the price is very expensive, it will not be reimbursed, especially in Europe. So this is really a problem.
I'd like to add, oh, sorry.
Just before you add on to that, there's a question, sort of subsidiary question or linked question in the question and answers there from Gonzalo. Would you like to add that question, Gonzalo?
Sure. Thank you. Good morning, everyone. So Cindra presented also the disparity of prices across Europe between, I believe, Spain, Germany, and France. And I would like to know if anyone is aware of a joint procurement efforts across Europe. I know there has been discussions about it on the testing front. I'm not aware on the PrEP front, so would like to know if anyone knows about it. Thanks.
Thank you. I don't know if Cindra or Jade, do you have any idea?
No, I don't have the answer to that.
Annie?
I don't.
Anise, do you have a beginning of to answer that question?
Sorry, just because we're having one microphone. So as far as I'm aware, there's no such, I mean, the European Commission has a joint procurement mechanism, which was used for Mpox and for COVID. And there's no such discussion. What would be needed is for national authorities to ask the Commission to put it on the plan. So then we would need to have community really strongly pressuring ministries of health to then, so that they ask HERA, the European Health Emergency Authorities, to prepare a joint procurement. But so it's really up to national authorities to ask for it.
That's exciting. That's good to know. But also, there was just a deal that cabotegravir is going to go generic. They have 3 generic. They have a license. They've licensed 3 generic manufacturers to make cabotegravir available in generic. However, I think that and that's for low and middle income countries, and obviously there's some middle income countries in Europe, but I don't know what that means for the wealthier countries. I think then you get into stuff like voluntary licensing and patent waiving. And I think it's incumbent upon Europe to go up against ViiV, because this is such a great it could be potentially such a great intervention, and Europe's not going to be able to roll it out unless the prices are somewhat comparable to oral PrEP, like Jade was saying. And also, just to say, there's not going to be availability of CAB for several years. Again, there's a stock problem, and unless they have to build the mills to make these now, and so these new generic companies, they're not even going to be up and running for at least a year.
Sorry.
Yes,
Just gonna try something. Yes, I was just wondering what, in relation to price, we haven't been too successful in reducing the price of sofosbuvir drastically. So I would be interested to see, and we had hoped, for instance, for joint procurement for sofosbuvir, but there was no interest from national authorities at the time. So I was just wondering what could be community strategies to put pressure on ViiV to reduce price. I mean, I think we have to push our governments to be good negotiators, but then why would, what is their incentive for governments to be good negotiator and prioritize this over other medicines? Right. So I'm just, this maybe requires a bit of creative thinking.
Yeah.
Well, for hepatitis C treatment, you would think that is an emergent, or that there's no alternative. So that would be a no-brainer, right? They would save a lot of money. But there's voluntary licensing where the community and the government can go up against ViiV and be like, you have to give us a license to roll this out. Or there's compulsory licensing too, that they can declare a health emergency, and just, under the WTO laws, they're allowed to import or manufacture any drug without the permission of the drug company. I mean, that's a whole, I doubt national authorities are going to go to bat for cabotegravir for that, but hepatitis C treatment might make more sense.
Yes, the question of pricing seems to come back and bite us every time we make a movement towards more choice, particularly when it comes to medication and drugs, where the innovation aspect means that the lower pricing is always more complicated as a result of the research and the innovation that's brought forward.
ViiV is saying, ViiV wants to see that there's a demand, that they will apply for a license in any country if they show that there's a real groundswell of demand. So that's one thing the community can do, is really make
the demand.
Yeah, and then once then maybe that's when the price negotiations starts to happen, when they submit their dossier for review of the national regulatory authorities. But they're really wanting to see demand from community and from the national governments.
Yeah. So perhaps that's also something that community can, well, advocates, not the community, can do is link in with their community even better and more consistently on what they would require in terms of new prevention strategies.
And if folks are interested, I mean, we do a lot of that at AVAC. We have a relationship with ViiV, and we bring advocates from all over the globe to them and get
to the table,
establish relationships. And so if you're interested in that from any of your countries, I'm happy to talk to you and bring you on board and get involved.
Yes, Harriet, thank you for your comment in the chat about and the capitals that you use there.
I don't see it.
And Isabel, you raised your hand.
Sorry, I wasn't planning on talking today, but couldn't help it. So I was just thinking, for demand to be made, it would be good, as Harriet said, for people to know about these options, but also to know that ViiV is open to, kind of volume price agreements or some kind of price reduction, because I mean, that would be good to, to motivate the demand. demand creation. And also that's something we keep on bringing up in the European community advisory boards with VIV. And we had also talked about these community manifestos, you know, like about with the different demand. So I think that will be quite important. Also to use the upcoming EACS conference perhaps to advocate on that side.
We have someone from EACS, I believe, here, or who is a representative at the EACS community space. Perhaps that's also something that we can try and exploit. So what I've heard from that part of the discussion, at least, is that we want as much choice as possible, that there are choices coming down the pipeline, and that the community needs to have this question about pricing and about availability and the numbers, of course. I mean, we have the old adage from colleagues at ACT UP, which was that knowledge equals power, and that obviously if we know that these options are available or are coming available, then we can build up demand towards that. And the question of how the community can mobilize, or shall we say, the advocates can mobilize the community to make our voices heard and have a place at the table, like you were mentioning, Cindra. Yeah.
If I might add, so PEPFAR, which is the program, it's a US program. PEPFAR and Global Fund are really sort of buying up all of the cabotegravir now, and they're really looking to, they're buying up most of it, which is not a lot, and they're going to be rolling it out in PEPFAR countries, which is a few in Africa and some in Asia. And so you can watch those spaces for how well it gets implemented. But yeah, they're sort of hoarding all the cabotegravir for now.
Okay. And then we have this effectively the question of perhaps asking for the EU joint procurement agreement to include HIV issues. I agree it's a cross-border threat. I seem to remember at one point in the EU history with HIV, it was considered as a cross-border threat to a certain extent, or at least a health emergency. So perhaps we could, as advocates, be fighting for it to be made.
For sure.
Given back that. And I believe, I'm not sure how the Spanish presidency of the EU next year, which is having or has a slant towards HIV or an angle on HIV, it may also be a possibility to bring some of these issues towards the question. Thank you, Anis, for the clarification. Yeah.
And you know, VIV, I'm pretty sure is the manufacturer is headquartered in England. Not sure how that. Yeah.
Well, I may go ahead. Okay, thank you, Harriet. I'm also trying to communicate with Harriet about the closing of the question and answers. Were there any other questions that you wish to ask, you, the people connected, at this point? Please feel free to unmute yourselves and take the floor. We have 3 or 4 minutes before I will be handing the floor back to Harriet for final comments and
I'm going to put my
contact
email
details.
So if please,
Yeah.
anyone with further questions, if you want to get involved, did I put
No.
a period?
I presume that's Cindra at AVAC, not .Cindra. Okay.
If anyone wants more information or how to get involved in advocacy for any of this, happy to bring you on board on the AVAC universe.
Okay, thank you, Cindra, for that. And with that, I will hand the floor back to Harriet.
Thank you very much, Richard, and Cindra, of course. And trying to sum up and sort of wrap up what we have heard in this lunchtime session is what's in the biomedical prevention pipeline. And I'm so thrilled to see that there is something, that there is really a lot of it, but also coming a lot of questions coming with this, what is in the pipelines. And I heard a lot about the ongoing discussion about how resistance is being seen, how important it is to have an eye on resistance, whether it is coming with a long-acting PrEP or even with the doxy PEP, we have those questions. And I'm also, I feel urged to repeat my remark that I put in the chat. If we want communities, and if VIV says they want the communities to become more active and more involved in advocacy, the first thing is that communities need to know, as Richard said, knowledge equals power. So this is why we are doing these webinars, these e-meetings. And now that we have heard what's in the pipeline, I think we are about to find out in our next meeting, which is being advertised next to me now in a very nice slide, on an e-meeting on June 7th, about the same time that we were meeting today. And this is a platform where we are going to discuss how can we as community, as activists, how can we support developments in PrEP implementation. So I'm inviting all of you to scan the QR code, share the QR code, and especially watch out for what EATG has provided already right now, a couple of minutes ago. We have put on our social media accounts the advertising of this next community meeting. So please register yourself and invite those who you think should become involved. And on this occasion, I probably should tell you that I'm also one of the community advocates that is working with AVAC, which is why I know Cindra for some time and why I can really recommend the resources on the AVAC homepage. And do reach out to Cindra, do reach out to all of us, and please share the invitation for the development in PrEP implementation issues. So we are a bit ahead of time. I can't see your faces right now if there are any urgent issues still. And if no one's stopping me, then I feel free of letting you go 5 minutes early to, here's another slide where you can send your emails, your questions to, and absolutely highly important, we want your feedback, because if you have any feedback, any remarks, anything to help us to improve our e-meetings, we are happy to receive your feedback. So please feel free to give feedback to Chiara and let us know what you want coming out from our next meeting on June 7th. On this occasion, and as nobody has stopped me yet, I'm saying thank you to our fantastic presenters. Jade, you're still here. That's fantastic. Thanks to merci beaucoup à Paris.
Merci à vous.
And the same goes to Richard, even though I pronounce your first name English. I know you're also based in France, and another merci to Richard. And Cindra, you also get a merci from me, because sometimes when you're in Europe and not sitting in New York City, you also do share some Francophilia. And thanks to our interpreters, I hope we were considerate enough to give you a chance to follow our English. And it's a great pleasure to be your host today. A big thank you to the EATG staff who helped prepare this, who did all the beautiful slides, and not to forget our beautiful backgrounds, purple, pink here, which I tried to meet in my outfit today. And now I let you go, wishing you a wonderful day and seeing you again on June 7th, hopefully. Bye-bye. Thank you.
Bye all.